Good evening, everyone. We're just going to give everybody a moment or two to log on, and we'll begin shortly. All right. Good evening, everyone. And thank you so much for joining us for In the Middle, Managing Your Midlife Transition. Tonight, we will sit down with practitioners across specialties to discuss all things midlife. In this installment, Susan Loeb Zeitlin, MD, FACOG, MSCP, Menopause Certified Practitioner, is joined by Jennifer Kinman, MD, from the Weill Cornell Medicine Genetics and Personalized Cancer Prevention Program, and Ashley Schreier, DO, from the Breast Center at Weill Cornell Medicine to discuss all things menopause and breast health. Tonight's session will be recorded and sent to all those who registered in the next few days. We encourage you to submit your questions in the Q&A section. And it is now my pleasure to turn things over to our speakers. Thank you all so much for being here with us tonight.
Thank you very much, and thank you all for joining us for this important topic. So just by way of introduction, with 1 in 8 women diagnosed with breast cancer, and the average age of breast cancer being 62, when we talk about women going through the menopause transition, it's really important to discuss breast cancer and what we can do to maintain our breast health. I'm sure we all know someone, probably multiple people, who have been impacted by breast cancer. Additionally, when we talk about menopause, we often talk about hormone therapy as a treatment. And after the Women's Health Initiative study of 2002 showed an increased risk of breast cancer in some hormone replacement therapy users, we have learned a lot about the risks of hormone therapy and breast cancer. So today I'm honored to be here with 2 incredible physicians who are experts in breast health, an expert in genetics, Dr. Jennifer Kinman, and a breast oncologist, Dr. Ashley Schreier. Dr. Kinman is a board-certified emergency medicine physician who works in the Genetics and Personalized Cancer Prevention Program at Weill Cornell, where she specializes in cancer prevention and early detection of cancers for individuals who are at higher than average risk for cancer due to family history or genetic conditions such as BRCA and Lynch syndrome. She received her BA from Duke University and her MD from Columbia University. She completed residency training in emergency medicine at New York Presbyterian Brooklyn Methodist Hospital and has completed additional training in cancer genomics and hereditary cancer risk assessment through City of Hope. She is a native New Yorker and enjoys bird watching in her free time. Dr. Ashley Schreier is an assistant professor of medicine within the Division of Hematology and Medical Oncology at Weill Cornell Medicine. She treats patients with all forms of breast cancer and has a special interest in caring for those with triple-negative breast cancer, which has been an emphasis of her research. Dr. Schreier received her BS in 2012 from Cornell University. She then entered medical school at NYIT College of Osteopathic Medicine, followed by residency in internal medicine at the Albert Einstein College of Medicine and fellowship in hematology and medical oncology at Weill Cornell. So thank you both for joining us tonight to talk about this topic. So let's start with Dr. Schreier, and let's just talk about the basics. So I said 1 in 8 women are statistically going to develop breast cancer. So what are some of the risk factors for breast cancer?
Thank you so much. Yeah, so some of the risk factors are, of course, family history. So actually only 10% of breast cancers are inherited. But women who do have a family history, particularly with a first-degree relative, so that being a mother, a daughter, or sister with breast cancer, are at an increased risk compared to the average woman. Other risk factors include patients who have a history of prior Hodgkin's lymphoma who have had chest wall radiation, patients who have never had children. That's a risk factor that plays a role in terms of the hormone balance throughout the woman's life, and also having a later time to first pregnancy, as well as an earlier time to initiate someone's menstrual period. So all of those things play together into sort of a multifactorial risk factors that can impact someone's risk. The other thing is breast density, which women can see on their mammogram reports. That also mildly increases the risk of breast cancer as well. And then, of course, general risk factors for cancer, including many types of breast cancer, include obesity, alcohol use, which has been directly correlated with breast cancer risk, as well as tobacco and smoking.
Those are really important because as we talk about menopause, we talk about lifestyle modifications. Those are certainly some modifications that can be made that can really improve health outcomes and aging well. So those are really important. So let's not talk right now, we'll get to them, about the high risk genetic people who have a genetic predisposition. But for the average woman, what are the breast cancer screening recommendations? When should we get our mammograms? How often? When should we stop getting them?
So the guidelines do vary depending on which society you follow. Typically, the mainstay of recommendations is to begin annual mammography at age 40 for an average risk woman, and then to continue mammograms yearly. We don't necessarily have a time where we say that someone is too old to have a mammogram. As we know, most breast cancers are estrogen mediated, so the estrogen that's in someone's bloodstream over the lifetime can increase the risk of breast cancer. So what that means is that every year of a woman's life, the breast cancer risk actually increases. And so we do recommend continuing screening, up until a woman feels that she's well enough to receive treatment, should she, develop a diagnosis of breast cancer.
And that's what I do in my practice too. We'll start, unless there's a reason to, at age 40, and then continue pretty much annually for, like you said, as long as a woman could be treated should she be found to have something on her mammogram. So that's exactly what I do. So then there's controversy, I think, among the medical organizations about doing self-breast exams. What do you think? Should a woman be doing self-breast exams?
Yeah, yes and no. I think I tell patients that it's a good idea, if they're able to, and I think it does help in certain scenarios, especially in young women. But it also does increase anxiety levels in our patients, and it's technically not, recommended across the board. So I kind of tailor that towards the patient. If someone is very compliant with their annual screening, I don't really enforce the need to do a self-breast exam. But I think if someone's really motivated, and they want to, do it, and they don't think it's going to take a big toll mentally, then I do think it is a good idea to incorporate. But I don't necessarily make it an across the board recommendation.
Correct. So, I mean, so not correct, but so I agree with that. And I think so many women come into my office after having detected something themselves. And the flip side of that, so many women get concerned. They feel something and it turns out to be nothing. But I think we as women know our bodies, and it's never a bad idea to kind of pay attention and note any changes that are happening.
Exactly.
So you alluded to the dense breast. You started talking about that. That is like the big thing that's, people ask about. So yes, it is a risk factor, as we know, for breast cancer if you have dense breasts. So women are getting reports on their mammograms, and at least 40%, if not more, read dense breasts. Speak with your provider about additional testing. And then, of course, Medicare isn't even covering the additional testing. That's a whole nother conversation. But let's talk about what additional testing could be done and the value of it. So one thing that's obviously the less expensive way to go is with an ultrasound to go along with the mammogram. What do you think about that?
Right, of course. I think Yeah, the ultrasound is, ordered by some providers to sort of act as supplemental screening. So the mammography remains the gold standard for breast cancer screening, and it can detect calcifications that we can't see on other modalities. Breast sonogram or ultrasound can add to the value and is recommended as an option for supplemental screening in women who have dense breasts. Because density is known to be a risk factor for breast cancer, as you mentioned, but also it's twofold because having dense breasts makes the mammogram, less able to detect small tumors. And so there's kind of both of those things going on for thinking about doing supplemental screening. And so an ultrasound is helpful. It doesn't really add that much value. I think it's quoted something to pick up in like 5 out of 1,000, times it'll pick up a cancer that the mammogram misses. More recently, MRI has actually made its way into the guidelines for breast cancer screening, particularly in women with dense breasts. As you mentioned, it's not always covered by insurance. So that's a little bit of a gray area. And I think eventually it will be. I think, it's made it into the guidelines more recently. So it's something that's kind of becoming part of clinical practice. And the reason why MRI is added is because it's a vascular-based test and it does, require IV contrast. So what it does is it's a highly sensitive test that can actually pick up on really tiny tumors that the mammogram and the ultrasound may miss. And so it definitely blows ultrasound out of the water in terms of adding for supplemental screening. It does not eliminate the need for a mammogram because, again, it cannot detect the calcifications that we see on mammogram. So in women with dense breasts, we have the option for doing this annual MRI in addition to the annual mammogram. And it's supplemental. So I only see patients who have a history of breast cancer, and I do offer it. I don't I don't recommend it across the board. And I sort of, we use joint decision making in my practice because in some patients, they choose not to do the MRI because the downside is that since it is highly sensitive, it can pick up on a lot of things that end up being nothing, and that can lead to additional biopsies with negative results. So there are a lot of false alarms, and that can increase anxiety. And so I do explain that to patients in detail before we decide to proceed with annual MRI screening.
And that comes up often in my practice too, because I am doing the screening, right? So Cornell is now offering an accelerated MRI, which is a quicker MRI for women with dense breasts, and it's, I believe, less expensive also. And so, as you said, we're able to offer that. We don't necessarily recommend it just yet, but we're offering
Right.
that to women who are, as you said, average risk with dense breasts. So that's a nice option and definitely picks up more. But the flip side of that is has false positives, which can also be alarming, right?
Exactly.
Yeah. One of our viewers asked us if Cornell uses any form of AI for screening. And so we still have radiologists doing every single review of every single image, but there is an option to have a computer also look at the images kind of to check on the radiologist if you pick up something that maybe the radiologist didn't see. Right. Any comments about that?
Exactly. Yeah. There's no image that's not reviewed by a radiologist here.
Yeah, I think I want to get to Dr. Kinman, but I'm going to get back to you about talking about like what we can do to maintain our breast health and um, down the road. But let's get to Dr. Kinman because that's really interesting what she does too. So Dr. Kinman specializes in the genetic causes of breast cancer and screening women for possible genetic links to breast cancer. So Dr. Schreier already said about 10% of breast cancers are known to have genetic causes. So who should get genetic testing?
So that's a great question. First of all, we are able to do genetic testing on almost anyone who's interested. It may not be covered by insurance in all cases, but there are criteria for who does meet kind of the definition of somebody who should be getting genetic testing, as long as they agree to it. Generally, high-risk features are considered to be a breast cancer diagnosis at an age of 50 or younger, a bilateral or multiple cases of primary breast cancer in the same individual, family history of breast cancer, plus also ovarian cancer, pancreatic cancer, breast cancer in a man. Again, breast cancer at a young age, being 50 or younger, lobular breast cancer, triple negative breast cancer, or simply a family or personal history of breast cancer and ancestry of being Ashkenazi Jewish. So that's just for the breast cancer side of it.
I have a couple of questions there. If you're Ashkenazi Jewish, should you get genetic testing? Just that factor alone.
If you have no family history of any cancer at all, and no known family history of any genetic mutation, I would say in that case, if you don't want to, being Ashkenazi Jewish is not a disease. It's not a reason to go get genetic testing, but it's certainly when taken together with a family history that is maybe not as high risk at appearing as it would be in the general population. For Ashkenazi Jews, there's a much lower threshold to recommend the testing.
So that was my other question. When you say a family history of breast cancer, a family history of ovarian cancer, what degree relative are you just talking about?
First, second, and third.
Mm-hmm.
So third degree relative, first degree is parents, siblings, children. Second degree, grandparents, aunts, uncles, grandchildren, nieces, nephews. And then third degree would be great aunts or uncles, first cousins, relatives that are related through one person, another person, and then that person.
So we live in such an age of information. A lot of people want to get all that information about their genes, their genetic predispositions. What are some of the pros and some of the cons? What are we about getting tested?
Sure. So let's start with the pros. I think very often people are able to uncover a susceptibility to other cancers that are either preventable or can be potentially detected at an earlier and more treatable stage, only if they're doing some extra testing that the general population would not be doing. So obviously one of the examples that we all now on this call know about is breast MRI. If somebody is not aware that they are higher risk and are only doing this sort of standard population level recommendations, which would be mammogram starting at 40, once they know if they have a genetic predisposition, maybe they would be starting on breast MRI, which is shown to be very effective at detecting cancers at earlier stages, smaller in size, more survivable. In addition, the genes like BRCA1, BRCA2, and also the less well-known and less what we call penetrant genes that are also involved in breast cancer risk also come with their own list of other cancers that are also increased in those individuals. So in some cases, there's an ovarian cancer risk, which can open the door to doing some preventative things eventually at a certain age in the genetic conditions where there is an increased risk for ovarian cancer. Generally, the recommendation is to do surgical removal of the ovaries and fallopian tubes after completion of childbearing and at the age where ovarian cancer risk is expected to start to climb. Some of these genes, including BRCA, especially BRCA2, can be involved in increasing the risk of pancreatic cancer, some melanomas. And then there are other genes that probably don't have as much name recognition that can point to cancers that you wouldn't think of, like stomach cancer, potentially. It's a long list. It really depends on which gene is found to have the mutation, but it really, I think, can create a great opportunity and save lives in not just the individual, but any relatives who, because of somebody doing genetic testing, finding out about a mutation, and then informing their relatives, doing what we call cascade testing, it can really save lives in the family. Of course, cons are, we always have to acknowledge that there is an emotional toll that comes with knowing this information. It can certainly bring up feelings of guilt in the family between individuals, maybe who did not inherit the mutation, maybe they have siblings who did, and they happen to, the hand they were dealt in their genetics just happened to have been a little bit luckier in that way. Certainly when it's a parent-child situation, there are definitely individuals who experience real feelings of guilt, even if it's, you know, obviously it's not their fault. There's nothing they could do but to know that they've passed something down that will make their children's health more at risk is concerning. There are also some issues that can come up that are not medical, but more about financial health. Knowing about a genetic mutation that predisposes somebody to cancer can create challenges with getting life insurance, disability insurance, long-term care insurance. There are legal protections against genetic discrimination by health insurance, but not for those other ones. So that does become an issue in a lot of our discussions.
That was a great answer, a very thorough answer. And that's actually why we send patients to you, because then you can do all of that counseling ahead of time, explain pros and cons like you just did. Some of my patients come to you, and then before they get their testing, they'll actually get their life insurance in place, and then they will do their testing. And and then you do the counseling should they come up with a genetic predisposition, a gene, right? So that's why we have this amazing program, and to have great resources for our patients who end up getting the testing. And then once the results are obtained, if someone does have a genetic predisposition, you already said this, but there's extra screening tests that can be done depending on what that gene is, that can detect things early and hopefully save lives, right? So that's the idea. So one viewer asked, and this is something we wanted to talk about too, we also, but besides the genetic testing, we can actually do mathematical calculations to assess a woman's risk of breast cancer. Can you just talk about that a little bit?
Sure. So we tend to do two different calculations for most of our patients. One of them is the Gale model, which is it takes fewer inputs. It's almost like a quick and dirty kind of risk calculator. It cannot be used for women who have had if they've had a diagnosis of any high breast cancer, any high risk lesions on biopsy, like LCIS, things like that, or if they have a known mutation in any of the breast cancer risk genes, you can't use this. But then for people who do meet the criteria for this calculator to be used, it'll take into account their age of menarche, which is the age that they first got their period, age at first birth, if they've had breast biopsies, how many biopsies they've had, and if any of those biopsies have specifically shown atypical hyperplasia. Anything more high risk on a biopsy would actually be excluded. And anything less than that would be sort of lumped in with a negative benign biopsy. And then it only takes into account family history of first-degree relatives with breast cancer history. It outputs a 5-year breast cancer risk and then a remaining lifetime breast cancer risk. We then also do a different calculator that takes a lot more inputs, and this is called the Tyrer-Cuzick score, the TC score. Takes into account age of menarche, height, weight, whether someone is pre, peri, or postmenopausal, if they've taken hormone replacement therapy, and if so, if it's been estrogen alone or estrogen and progesterone combined. It takes into account also breast density on mammogram, Ashkenazi Jewish ancestry, and then family history of breast cancer and ovarian cancer, including breast cancer in male relatives. And it goes all the way out to the level of cousins, which is third-degree relatives. And that will calculate a lifetime remaining risk and also a 10-year risk. And generally that is the one that I think most of us are looking at a lot more closely in terms of determining if somebody meets kind of that high risk criteria, where we would recommend the breast MRI, and usually starting breast MRI at an age younger than the 40-year-old age for mammogram. And it also does calculate a pre-test probability of testing positive for a mutation in BRCA1 or BRCA2.
And so that actually is, you can Google it and do your own Tyrer-Cuzick score, and put in all of that data and find out your risk and then seek care based on that. I mean, we do it in the office. It's very easy to do, and they do, Dr. Kimman does it also, but that
I
is
would just
available.
I would just add something really interesting that the Tyrer-Cuzick model does is it also takes into account relatives who have not had cancer. So if somebody has a family, a very small family with very few aunts and no sisters, it can tell the difference between that and a family that has 8 aunts on both sides and a bunch of sisters and no breast cancer and no ovarian cancer. That has a lot more ability to say, you know what, this person has a lot of people that are genetically similar who are female, who have never had breast or ovarian cancer. And they can actually use that to say potentially the risk is lower than in somebody who maybe has no family history, but maybe both is an only child and their parents were only children, and maybe their grandparents died of something else at a young age. So there's almost no natural history to really observe in their relatives.
That's interesting. When you go through the model, it does ask number of sibling, a number of, and so that's why that's interesting. Men should also be tested genetically, right? If there's a reason, right? There's no reason not to.
They absolutely should be tested. Yeah. These genes not only these genes are in men. These are not these are not genes that only women have. And there are risks associated with BRCA and many of the other genes that are considered to be breast and ovarian cancer genes or some other cancers that are thought of as women's cancers. There are genes associated with those that also are involved in colon cancer and pancreatic cancer and organs that are equally at risk in men and in women. And there is also a higher risk of male breast cancer, especially in BRCA2 carriers. And there's a higher risk of prostate cancers and more aggressive prostate cancers at younger ages in some of these genes, especially BRCA2.
Someone asked, is testing covered by insurance, and how expensive is it?
So it depends on your family history, but very often the answer is yes. And when the answer is no, the labs that we work with that do the genetic testing, which is there are labs outside of Weill Cornell. Most of the labs that we work with have basically some arrangement where for people who have a high out-of-pocket cost, they will give them the option if their insurance is like refusing coverage, they will offer it to people as with a self-pay option, basically not bill the insurance and just bill the patient at a fixed rate of $250. So, and even with that, if there is a case of financial hardship, the labs will all work with patients where they'll generally offer it for free if there's a good reason.
Great. So I encourage my patients, if there's any reason, to seek, an appointment and discuss it and learn if it's going to be covered and learn if they're a good candidate and learn the pros and cons. So that's why we have this amazing program here at Cornell. So we can't do a webinar about menopause and midlife without talking about it, right? So especially hormone therapy. Menopause is, as we know, is having its moment, and a lot of people are wanting hormone replacement therapy, or wanting to talk about it at least. We know it is the most effective treatment for menopausal hot flashes and night sweats. Also has many other benefits for certain women, including protecting bones and even some cardiovascular benefits. But we've come a long way since the Women's Health Initiative study in 2002, when we pulled it away from everybody and nobody wanted to use hormone therapy because of the fear of breast cancer. And as we looked at the Women's Health Initiative study over the past 20 years, especially with regards to breast cancer, it seems that if you use hormones estrogen and progesterone, which you need if you have a uterus, for 5 years, we really don't see much of an increased risk of breast cancer. And if you um, use it longer, it does incur a small increased risk, but they actually liken that risk to a woman who drinks 2 glasses of wine a day or is obese. So again, those are not huge risk factors. And so for many women, they can safely use hormone therapy. So I'm going to ask Dr. Schreier what your thoughts are about hormone replacement therapy and breast cancer in women who don't have breast cancer. If you have breast cancer, we have alternatives. And someone asked me that question in the chat. We have non-hormonal medications for someone who has a history of breast cancer. Most of the time we don't individualize, but most of the time we don't recommend hormone therapy for women who've had breast cancer.
Right, exactly. So yeah, in my practice, we don't really use hormone replacement therapy because all of my patients have a history of breast cancer. But in the general average risk population, I agree. I think it's a risk benefit discussion that really depends on quality of life issues, patients' values, patients' risk tolerance, all of these things that play a role. But again, the risk is just, it's another risk in the realm of, all of the environmental factors that are present to increase the risk of breast cancer. And so it's, I don't think the risk is high enough to say that nobody should use it. But of course, there are patients that are super anxious and for those patients, it's probably something that they wouldn't want. But in a woman who is interested and it really would make an impact on quality of life, I think it's not something that is contraindicated from a breast oncology standpoint.
And so for a while, I would tell women after 5 years of use, we should start weaning. And now, really, the tune has changed a little bit, and it's very much, as you said, shared decision, individualized based on quality of life, what symptoms we're treating, why we're using the hormones. And there's no one way to do this, but there's no absolute stop at 5 years of use either. And I think that's really
Right.
important. I mean, there are studies that have gone on about the types of breast cancer, if women on hormone therapy do get breast cancer. Is it a different type of breast cancer? Is it a more treatable? And some studies have shown that too.
Right, exactly. Like it's likely to be a hormone receptor positive, low grade, not aggressive type of breast cancer. So that's comforting to know. At least like these are things that are super curable and probably will be detected on imaging. It's not necessarily linked with like the high grade, triple negative cancers. So that's another thing that is important to think about.
I'm also
Definitely.
going to throw in there something I've talked about on other webinars. The use of vaginal estrogen can be safely used in most patients, and in consultation with with our breast oncologist, we can even sometimes use that in our breast cancer patients. Again, always in consultation with the breast oncologist, but that is not considered hormone replacement therapy. That is local estrogen therapy, and that's very different, but can safely be used in most populations. Um, do you think a woman who's on hormone therapy should have any extra breast screening?
I mean, there's no data for that. Like you mentioned, it's the same as someone who drinks, a lot of alcohol or someone who's obese. And it just sort of adds to the many risk factors that each individual woman may or may not have. And so I think, if a woman is compliant with yearly screening and regularly, seeing her doctor, there's no need for any excessive breast screening.
And Dr. Kinman, when you have a woman with a genetic predisposition to breast cancer, but no known cancer, um, are 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 you able to talk to them about hormone therapy?
Yeah, I mean, we allow it. There's not really any cases where we would say that for just a genetic predisposition, but not a diagnosis, where we would say that somebody shouldn't be able to use these drugs.
Right. Right. Again, it's a shared decision, individualized. Um, there's some great questions coming up in the chat. I'm going to try to get to a few of them before we I want to throw one more thing out there that women, I said it at the beginning of this part, but when women who have had breast cancer can manage their menopausal symptoms, there are non-hormonal medications. There's really good evidence that cognitive behavior therapy and hypnosis even can help symptoms of menopause, in addition to some very good non-hormonal medications that we have. So don't despair if you've had breast cancer or if you feel like it's not right for you, there are other ways to manage your menopausal symptoms. Dr. Kinnan, this question is hard to answer. What is the percentage if you have a gene, like a BRCA gene, that you will get breast cancer?
Yeah,
And
so
is it possible that you won't get breast cancer? The question says.
it's always possible to not get cancer. Yeah, so generally, let me just pull up my tables quickly. So with BRCA1, the current risk estimate for lifetime risk of breast cancer is between 60 and 72%. And for BRCA2, it's similar, it's 55 to 69%. Do you want to also hear about the other cancers with BRCA?
Sure, why not?
So for BRCA1, the lifetime risk for ovarian cancer is 39 to 58%. And a little bit lower for BRCA2, it's 13 to 29%. And then for pancreatic cancer, for BRCA1, it's less than or equal to 5%, probably somewhere higher than the general population average, which is between 1 and 2%. BRCA2, it is between 5 and 10%, which is a several-fold increase over the general population for pancreatic cancer. And then these other the other breast cancer risk genes are considered lower penetrance than that. They range from kind of 21% to 40% kind of numbers, depending on which gene we're talking about.
Right. And so that's why it's important again, that's an individualized thing. If you have a gene, then how you get screened, but you don't automatically get cancer. Although it feels like scary, it's true that you don't, but might as well do the screening. Great. I'm looking through some of these other questions. The immune system does play an important role in our risks in general. Wait, do you have a comment about that, Dr. Schreier? The importance of the immune system in like risks for breast cancer?
You know, and it's hard to pinpoint how that plays a role. I think, breast cancer is so common, and I think a lot of women, once they are diagnosed, are trying to search for a reason, why they got breast cancer, but most of the time we can't necessarily pinpoint something. Immune health, having a strong immune system is theoretically helpful in prevention for cancer. So one of the hallmarks of cancer in general and breast cancer also is the evasion of the immune system. So our immune system is always circulating and trying to find foreign things like infections and cancers that are popping up. And sometimes the immune system can actually work, its counter effects against that cell abnormality that's going to become a cancer and sort of prevent it from manifesting into a true cancer. And so, in theory, if someone has a strong immune system, they should be able to, fight off more of those developing cancers. We don't know necessarily for breast cancer specifically how much of a role that plays. Like on the flip side, we know that patients who are on, let's say, immunosuppression, patients who have had a transplant, a kidney transplant or a heart transplant, they're on medicines to suppress their immune system, and they are at higher risk of developing cancers compared to the general population. But the risk of breast cancer in those patients hasn't necessarily shown to be higher than the general population. And so we can't say for sure that, having a strong immune system necessarily has a protective effect. It's definitely an interesting concept. It's just we don't have necessarily the data to support that. But that being said, like any factors that can help with boosting your immune system are also beneficial, across the board for preventing cancer, breast cancer, and benefiting breast health, like exercise, healthy diet, and those sort of things for sure.
So that's a segue into how I want to close this webinar tonight, because we talked a lot about risks for breast cancer. So what can we do to maybe maintain good breast health? You know, living a healthy lifestyle with a good diet and exercise are probably the best things we can do for cancer prevention of all types, not just breast health. Anything specific that you can say in terms of breast health and what we can do to try to maintain our health?
Yeah, so like you said, diet and exercise. There is a lot of interesting data about exercise, even in our patients who are on treatment for breast cancer, that it can actually have a benefit in helping chemotherapy to work better and helping prevent breast cancer from recurring in patients with a history of breast cancer. So we do really emphasize exercise, routine cardiovascular exercise for a minimum of 30 minutes, minimum of 4 to 5 days per week. That can actually help to prevent recurrence of breast cancer in people with a history. And so, I think we can pretty much extrapolate that to some degree in the general population, right? So exercising regularly does have a benefit in cancer prevention and can really support breast health. And I think we probably will have more data on that, in the coming years. And then along with that, diet, many diets have been studied in terms of, both for patients with cancer, but also in terms of prevention. I think the diet with the most data is a low-fat diet, but there is also a lot of data for plant-based diet. And so a focus on plant-based proteins, not necessarily going, full out vegan, but having a focus on plant foods and plant proteins as replacements for other animal-based proteins can help to reduce cancer risk. And specifically, there is data with breast cancer. And so that's one thing to sort of just be conscious of, those sort of small changes in diet. Minimizing fat is also a big one that's important. And then the other thing that a lot of people don't realize is alcohol. So alcohol has been directly linked with breast cancer. And so we recommend a maximum of a drink of 1 glass per night, but we try to keep it even less than that. Under 5 drinks per week is typically what we recommend, because once you hit 7 to 10 drinks per week, that's when the risk really starts to increase. And so it's just another risk factor for women. But when you're trying to maximize breast health, minimizing alcohol, on a daily and weekly basis is important. The diet, the exercise, those are pretty much the big ones. Oh, and the other huge thing is BMI. So, aside from diet and exercise, if you're overweight, your risk will increase, because most breast cancers are estrogen mediated, and every fat cell that we have in our body produces estrogen. And so in a woman that has excessive fat, they have more circulating estrogen. And so their risk is directly, just correlated with an increased risk of breast cancer. And so keeping a normal weight, keeping a normal BMI is a huge risk reducing strategy for patients worried about breast cancer.
And all of those things you said are also what the American Heart Association recommends for cardiovascular health, right? 150
Exactly.
minutes a week of moderate intensity exercise, a plant-focused diet, which is what I like to call it, focusing more on the vegetables, maybe not being strictly vegetarian, but plant-focused, BMI lowering, and American Heart Association is currently saying no alcohol. So, it's all these things are linked. Dr. Kimman, do you have anything to add to this?
I in certain select patients, and I don't want to open too much of a can of worms here, but for patients who not necessarily are high risk because of a genetic mutation that we identify, because it's really not been studied and really proven in those patients, but for patients who have a much higher than average calculated risk, what we call empiric risk, that Tyrer-Cuzick estimated 10-year or lifetime risk, the Gale model estimated 5-year lifetime risk. There is the option for women to do something called chemoprevention, which means taking one of the hormonal medications that are used as adjuvant treatment for women who've been diagnosed with ER/PR positive breast cancers. So this would be drugs like tamoxifen, raloxifene, anastrozole, the aromatase inhibitors, and the SERMs, the selective estrogen receptor modulators, can be used for a 5-year course to cut down on the risk of developing breast cancer. These drugs, of course, come with side effects. Many of the side effects are typical anti-estrogen side effects that are experienced in natural menopause. So hot flashes, changes in libido, musculoskeletal pains, hair thinning. But the risk does decrease during the 5 years that someone's on these medications, and probably for a number of years after they stop. However, none of the data support that the breast cancer mortalities, meaning the risk of dying from breast cancer, is in any way impacted for better or for worse with these drugs as prevention, which is not the case when you take these drugs as treatment. So a lot of, it's something that I bring up with patients who are a little higher risk than average for their age, really not younger than 35, and typically more in the menopausal, postmenopausal age patients, that this is an option. And very often, almost, I would say the vast majority of patients decline the option to do this because they feel that with the aggressive screening that we're doing, annual mammogram, annual MRI, if someone is high risk or has, they're high risk if we're having this conversation. So they would be getting annual MRI, self-exams, once or twice a year, clinical breast exam. The idea is that early detection and identification of breast cancer generally does result in great survival. And to take a medication that is going to impact quality of life just to prevent something that would be treatable with the same medication, a lot of women opt not to do it. But it is something that we always discuss, and it's certainly an option for women who want it.
It's a great point. And again, as everything we say, it's individualized and with a shared decision. Right. Any final thoughts that either one of you want to share? I think this was really thorough, really informative. I can say, talk to your primary physicians, your gynecologists, your primary care about your family history, about your personal concerns about your breast. Make sure you do your screening and focus on this healthy lifestyle. And I think these are really important messages for our, number one, our long-term health, but also for our breast health. If you have anything to add. Otherwise, I thank you guys so much for joining me tonight and sharing your wisdom, and get screened.
Yes, that would be my final thought. Stay up to date with your mammograms. Definitely. Thank you so much.
Yeah, I would add a final thought. Obviously we've been speaking mostly about breast cancer, but when we do these genetic panels, we're not only looking at the breast cancer related genes. It's a large panel that includes genes related to other cancers that are beyond the scope of this discussion, but certainly can be very helpful in other types of cancers that run in families, including colon and endometrial, which are probably the next most common ones that we see sort of running in families in like a familial cancer syndrome kind of way. And it's part of the test. It's not any additional cost or any additional criteria that one would have to meet to do that to find out those kinds of answers, even if they're doing it because of concerns about breast cancer.
Absolutely. All right. Thank you for joining us tonight.
Thank you so much.
Thank you so much.